Numerous anterior and posterior approach lid lowering procedures have been described. Most involve release and/or resection of variable proportions and layers of the upper lid retractors. This video demonstrates recession of the upper lid retractors via a posterior approach. A 4-0 traction suture is placed through the grey line and the upper lid everted over a Damar retractor. A small, full-thickness incision is made through the conjunctiva and tarsus close to the superior edge of the tarsal plate. The blade can almost be felt to pop through the tarsus. The horizontal incision is completed medially and laterally with spring scissors. The small portion of superior tarsus will provide firm tissue to hold onto whilst dissecting between mullers and levator. The traction suture is released and the Damar used to retract the upper lid whilst the relatively avascular plane between mullers and levator is dissected. The dissection is continued superiorly to the white line, which is almost always visible on the posterior surface of levator and is probably the point at which mullers and levator merge. A small buttonhole is made in the levator. The superior edge is grasped and the transection of levator continued medially and laterally. The pre-aponeurotic fat on the anterior side of levator is now visible. The lateral horn invariably also needs to be cut. Otherwise, the lateral flare that is commonly present in patients with thyroid eye disease will not be corrected. When cutting the lateral horn, care is taken to ensure that the scissors are angled medially to avoid transecting the lacrimal ductules. The levator can also be released from the pre-aponeurotic fat, as you see here. The lid position is checked at this stage. In this case, the lid remains slightly higher than desired, and the levator is further released. The lid is now at the desired position.